Okay, good evening, everyone. Um, you're welcome to the month of September's Own Your Future Mentorship program. And the seminar for this month is on ultrasound in acute care medicine. And we have the privilege of having Dr. Frank Myslik here with us. He's an emergency medicine consultant with London Health Sciences Centre and St. Joseph's Healthcare, London. He's an assistant professor at Western University, London, Ontario. He is also the director and creator of Western University's Emergency Medicine Ultrasound Fellowship and a trailblazer in the research, application, and training for clinical use of point of care bedside ultrasound technology. We have with us here a leader in a point of care medicine, actually, and his seminar today will be highlighting some of these things. I'm glad that here already we have a lot of participants that are also clinicians, and we believe we'll be benefiting from his seminar today. So without wasting much of our time, I'll just like to welcome Dr. Frank to um, have his presentation with us. Please, if you have questions, you can feel free to drop it on the chat box and he will attend.
All right. Thanks for having me, everyone. So, recognizing kind of the breadth of where this is coming from in terms of the series, and that this is kind of primarily MRI. But what I'll talk about a bit is how point of care ultrasound has kind of changed quite a bit for us in the acute care environment. And I would say mostly in medicine too. And it's always hard to kind of know exactly what it is to focus on. What it's such a giant topic, and so where we're just going to kind of go back into is a little bit of the history, a little bit about why do we care about this, like why do we even need point of care imaging? Why it's so disruptive? A bunch of clinical cases, a lot of impactful environments, but then always the pearls and pitfalls with going down it. So we'll kind of fly through this, and then if there's any questions dynamically, I'm always happy to take them as we go. I'll keep a little eye out for any hand raise or the chats, but just feel free to unmute if you feel that there's anything you want more clarity on. So we'll just kind of fly ahead here. So I don't have any conflicts of interest to declare. And at the end of the day, I always like to think POCUS is awesome. It's one of probably the most changeful things that I've had in my career. And one of the biggest things that I think brings us a lot of interest. Medicine sometimes doesn't feel like it takes leaps and bounds in the ways that we kind of hope. And so it's actually quite interesting about how much our clinical care has changed, but then also how it's created whole new problems too. So we're going to go on an adventure. We're going to go back through, and for all our Tolkien Lord of the Rings fans here, I always love a good reference. So let's talk a little bit about this first. And really, it's all about what is POCUS. It's and what it kind of entails. So this book, and it's not important that you've read it or even have to read it, but it basically talks about disruptive technologies. The idea of what is a disruptive technology, and then how do we kind of adapt to it. Essentially, looking at new price, low alternatives to existing technology that kind of meet users' minimum requirements, but then how they have to adapt to it over time. And so it really kind of puts technology in two different categories. Sustaining. So the idea of a sustained technology where it just slowly kind of changes with time. A good analogy of this would be like a hard drive. It gets bigger, it gets faster. We have solid state, saves a lot more data, but it's kind of like very incremental. Even the iPhone in its current state would be kind of relatively incremental. But then there's also the disruptive piece, the idea that it totally changes our entire paradigm of a current environment. A good comparison here would be, say, the iPod when it came out way back years ago. We went from physical hardware and CDs, and all of a sudden now we have this digital media, right? So it disrupts the entire music industry at that time. So think about it like that when we think about POCUS, and we'll rope back to that in 1 second. And again, I'm going to bring some comparisons that are probably North American based, but they're relevant for a reason. Large corporations are kind of designed to work with sustaining technologies. They're built around the concept of a technology, and they kind of build and add little modifications over time, make it better and get better with it. So they know their market and they stay close to what the customers essentially want, keeping a mechanism in place to kind of slowly develop it. But they actually sometimes have quite a bit of difficulty capitalizing on the potential efficiencies and these new disruptive technologies. So the ones that I kind of highlight here would be like the Blockbuster. So for anybody who knows about North American culture, this was a video rental place that was so ubiquitous that it was huge in the 2000s and even early 2010s. But then it got just totally derailed by Netflix and streaming services because it didn't adapt to the technology of online streaming. And then we have here in Canada and the US, we have the post office, right? But again, almost displaced by email, not really adapting or doing well with a whole technology piece that comes on the play. And then when we think about taxis, Uber is a great example that had a whole new technology piece that essentially sort of disrupted their entire fundamental technologies or their fundamental system. So, when we look at it like that, we can add very similar to what POCUS is. Think about the patient as the customer. They come in with shortness of breath and chest pain, and doctors are service providers essentially, right? They come in and from different specialties. Radiology and cardiology are essentially the established service providers. They provide comprehensive ultrasounds, whereas new suppliers would be specialties where it's become more relevant. Anesthesia, emerge, internal medicine, even some surgery, right? So they've come in and basically taken this entire new technology and applied it to a whole space where medicine's not really apt at changing quite quickly. And so if we look at the comprehensive ultrasound trajectory here and compare it to the point of care ultrasound trajectory, it's all about patients kind of demanding high-tech examinations and where that POCUS can actually kind of bridge a gap, especially in a day and age where like resources become more and more finite. And so it also is relevant when we talk about why it's got here. Like, why do we even need this new technology as part of it? And one of the biggest things is this depreciation of the physical exam, at least kind of in North America and even in Europe, that's really taken part. The idea that I've listened to your chest. I've felt your belly, and ultimately when it comes down to it, it really doesn't feel like people really care about it as much anymore. Whether that's talking to another specialty or an individual patient or even your own colleagues at times. It's also, we have a very image-driven culture. We have a culture where if you don't take a picture or you don't have an ability to look inside, it can be very challenging to convince someone nothing's wrong. So we just talked about the physical exam not being as relevant, and even though I think it has a lot of relevancy, but sometimes the perception's not. We as a culture want pictures. We want more tests. Look on the inside, imaging, MRIs, ultrasounds, X-rays. Like, do a picture and tell me nothing's wrong. So that's part of the other issue is that it's kind of created this idea of like, well, we need a low cost or a readily available alternative to be able to bridge that gap. And we've also had this kind of decline of other tools. So at the top left here, we have the Swan's Gath catheter, which is used in critical care environments, and it really has fallen a little bit at the wayside in some centers where now kind of POCUS has kind of come in there and disrupted that. And in the bottom left corner, we have what's a diagnostic peritoneal lavage, for example, in trauma, where they would essentially go in and see if there was any fluid in the belly. And again, that's kind of trended towards the lesser degree as well because we've had that decline in that tool. Again, POCUS coming in. And we've also had this miniaturization too, as it culturally across the globe, we've really gotten smaller with time. If you think about the telephone and what it used to be, how it got more handheld, and now we essentially have the iPhone, which obviously has gotten a little blip if you get the like iPhone Max or the Galaxy Notes, but really things have gotten smaller, and we like portability, we like that ease because with miniaturization typically comes lower cost with a lot of caveats to that. But as a whole, we like smaller things. And for all our archaic Zoolander fans out there, it's always a good moment to insert this clip. And so when we look back at ultrasound, ultrasound used to be this back in the 1950s and 60s, large devices, as it's kind of trended a bit more to, big cart-based ones, right? And this is kind of in your mid 80s, early 90s. But then we've gotten better and technology's trended in more direction. We've had sleeker machines and high def ones. But then we've actually been able to move towards cart-based ones. This is kind of the typical POCUS space that we see here in the bottom left corner. The idea of a cart that can manually be pushed around, so the footprint's a lot less than that one you see in the top right. But that whole miniaturization piece, we've trended even smaller tablet versions. And if you really want to go on the spectrum, we now have the ability to go back and basically plug in devices. So what we have on the left is the Butterfly device, and on the right is the Lumify. And I'll tell you right now, there is a ton of devices globally by different companies that essentially can Wi-Fi to your phones, tablets. And so it's really gotten pretty ridiculous in a good way about how easy it is to achieve this technology piece. So if we want to go back here for a second about where this all came from, nice little Back to the Future reference for anybody who gets that in a DeLorean. We go back to where it all came from. And in this case, it all came back from the trauma. Like this is where POCUS started, essentially. Not ultrasound. Ultrasound existed for a while, right? But then we had this whole idea where we had multiple injury patients that came in after large highways accidents. And here we have an example of one coming in, the controlled chaos of emerge and trauma teams, basically all coming in and trying to figure out who needs imaging and who doesn't. And again, depending on where you work, imaging can be readily available or very hard to get. And so, are they bleeding? Is it in the abdomen? Especially if you look at vitals that look like this: high heart rate, tachycardic, low blood pressure. What kind of shock is this? Is it shock due to neurological? Is it because they're bleeding here? Is there something going on in the head? And it can be very challenging to know where to prioritize things, especially when, depending on your pathways, people may need to go to the OR, but you also don't want to send people unnecessarily there. So, this is what we used to use, and we talked about it briefly earlier, the peritoneal lavage, basically getting in there, seeing if there's any blood. Well, what we've essentially done now is had a better mousetrap for that using the POCUS machine, right? Basically, it's again not a new concept. In fact, it's been used for years, but it's the ability to now bring that machine and look in the belly. Is there fluid, essentially? And then can we triage patients a lot more effectively? Can we essentially figure out where to send them afterwards? And so what that gets to is the focus assessment with sonography and trauma, or what is called the FAST exam. And you'll hear that probably utilized. Probably the most common with POCUS is the FAST. The FAST is essentially where it all came from, looking in the moment of a trauma, is there free fluid in the belly and around the heart? It's less invasive, it's faster, pretty safe in pregnancy. And so when you have people in trauma that are pregnant, exposing them to unnecessary radiation is always a bit of a challenge and something that really has to be thought about. But it's also repeatable. Remember, a lot of these other images are static, right, when you get them. And so the idea of POCUS is that you can pick up the probe and look again pretty easily. So you have the ability to see what it was and what it is now. And it's pretty helpful in terms of figuring out, a dynamic change and where to, what could be causing, an evolution of the vitals. It's not so easy to go back and forth to CT scans, right? There's no complications. Admittedly, though, it's not 100%, right? It's not as sensitive as, doing what used to be the DPL, but it is, as everything above, a lot easier to reproduce, and it's a lot less invasive. So let's just briefly kind of go through this just for context. The FAST exam involves several different areas. We look in the right upper quadrant between the liver and the kidney. We look between the spleen and the left kidney. We look around the bladder. And we also look around the heart. And so the core views that we essentially look at here are right upper quadrant, left upper quadrant, around the pelvic area. So we use the bladder as a window and looking around either the bladder or uterus if you're a female. But very commonly, we also forget it's the heart, looking right around that pericardial area to think, is there a pericardial fusion within this trauma? And so just a few examples here that if this is where you're scanning the right upper quadrant, you got your kidney, you got your liver, and what you're essentially looking for is between that interface is there any anechoic fluid or black fluid, which in the context of a trauma, you would just basically suppose is essentially bleeding. And so in this case, we have what is called the positive study. So you have the liver on the left side of the screen, you have the kidney down in here, and then you're looking at this black stripe right in the middle. So in isolation, you could scan people with things like ascites and that and see free fluid. It's not that it's an uncommon finding in certain other patients, but in a patient with a massive trauma that should have no reason to have it, you basically got a positive study here. And same thing here, just kind of looking, is there fluid? And it can be very subtle, right? What I just showed you before compared to here. And if you take a look in your corner eye right in here, you can see a black sliver start to appear right around there, essentially, again, having a positive study. So that can be a big difference, though, if you're in a resource depleted environment where you might need to transfer somebody out, you might need to get further imaging because you may not be a center that has access to advanced imaging or even CTs or even X-rays, depending on where you are. This could be a triage. This could even be in the field, depending on where you are. There are a lot of areas that use this with their paramedicine in deployment for traumas or their rural regional environments. And if we want to look onto orientation when we come to the pericardial scan, and I appreciate there's a lot of comprehensiveness to cardiac, but the very fundamental one is coming in the subxiphoid, just inferior there. And basically, you're looking at the heart itself. And so if we said this is the liver, remember, we're coming down from underneath the subxiphoid. We're looking around the heart and we can see the contractility. But more importantly, our eyes are kind of training right in here, that right between that in the pericardial space to see, is there any fluid? And again, just so you can see them side by side, on the right side here, we can see that black anechoic area surrounding the heart, pericardial effusion. And again, in a traumatic patient, you can already assume that's a hemopericardium. What you do with that is obviously depending on where you are and what the patient looks like, but it's more of that indication to say, I at least know what's going on now. So if we kind of move along to some other common core indications that essentially have popped up for medicine over time, and especially in the emerge, it's this common elderly or even older patient that comes in with new epigastric pain, feeling lightheaded, radiating to the flank, and then you're looking at these vitals on the right here, hypotensive, tachycardic, and so for us, this is a ticking time bomb to rule out, is there a ruptured aortic aneurysm about to burst here? Is there basically that gusher that's about to explode? And is this someone that we need to urgently get imaging on? And so again, easy enough if you have CTs, but sometimes when a patient is unstable, they're not able to get to that imaging. And even that 20 to 30 minute delay, even an hour can be huge. Depending on where your center is, you might get pictures and have to wait a number of minutes to hours to even get a read from a radiologist. And so being able to involve your specialist earlier on is key, especially when this is what you're worried about. For context, on the left here, we have a CT, and this is on the right, the POCUS. And essentially what you're looking at here is you're using the spinous process as your landmark right back in here. And essentially you're looking at your aorta right in this area. And beside that's the IVC. And so where this can basically be helpful is especially if you put the probe right in the middle of the belly there, just inferior to where we almost did that pericardial scan, tip the probe up, and then you're going to move it all the way down to the umbilicus. You can scan the entire length of the aorta. And so from here, we can say, is there evidence of a AAA? So if I said on the left side here, this was a normal scan, and as you can scan down, you're looking at basically the aorta. You're going to keep pushing, scanning, scanning, and then you actually see it bifurcate off there. So we've essentially done a pretty good, and if not comprehensive, look at the entire abdominal aortic, length, and we've essentially ruled out there is no AAA here. But on the flip side, you may find something like this. And so these are obviously real cases that we've had before, but more importantly, this patient presents in the acute care scenario, with the vitals I just showed you. And yeah, like it's a ruptured relay, or at least this is probably something that's going to rupture. And so you can arrange imaging, but more importantly, you can involve the appropriate specialty that you need to in your environment to get involved in this, or more importantly, start working on an urgent transfer, depending on where you are. So again, at least it's better to know what it is you're fighting than it is to deal with the unknown. And that's where the point of care imaging comes into play. And another one common here, this is a one that we see very commonly in the acute care environment. Tachycardic, hypotensive, young female. Is there an evidence of a intrauterine pregnancy? So an actual feasible pregnancy in the appropriate spot, or is there something more sinister going on? And so, you know, on the left side here, we basically see what is a uterus, and we see what is probably a gestational sac within on the inside there. But on the flip side, what we can also worry about is something like this, where we start to see pelvic fluid right in here, again, on that POCUS imaging. Because when you have a young female, we already said that if you're worried about pregnancy, you don't want to just CT them. And don't get me wrong, you can order diagnostic comprehensive imaging, but again, it's the timeliness that is the most important. If you work in a spot where it has radiology 24/7 and you got a tech just sitting right on the back bench there ready to pop in and do a scan anytime, it's not as important. But in a lot of centers, you don't have 24/7 access to radiology scans like this. And more importantly, it can be very challenging in an environment where you don't have it, and how much do you have to care? So again, point of care imaging can be very helpful, and it's a tangible picture that you can show someone because there's not many other causes for what's going on there. And so those are the most common ones, at least from the acute care emerge, that kind of spectral, or from the spectrum of where we started and where we're going, but it's kind of more the tip of the iceberg overall. And so POCUS has a lot more to offer. When we talk about one like this, for example, we have someone that presents, they come in, fever, flank pain, dysuria, so burning with peeing, and they're tachycardic, blood pressure's okay, but they're febrile. And so, we might find this, right? CVA, costovertebral angle, tenderness, but in their urine, they got some leukocytes, some blood cells, and we think to ourselves, okay, well, their white count's up, but their kidney function's fine. They're, pretty young person. They've never had a history before. This seems like pyelonephritis. But it can be challenging to know, how do you know there's not other something else going on there, right? And so this is where the POCUS comes into play once again, because you can look for things like hydronephrosis. And so if you were to look at someone like this here, so on the left side of the screen, I was to say this is a kidney and this is a normal kidney. What you're essentially left with here is hydronephrosis. And if I can convince you it looks something like this, hydro basically is a backup or an obstructionary process downstream. And there can be a lot of reasons for that. But the more important ones is whether it is a kidney stone. Now, a kidney stone, by definition, is not time sensitive to immediately diagnose, but it certainly is if someone is febrile with all the urine symptoms that we saw earlier. And so what we're essentially left with here is someone that we may have just treated with antibiotics, essentially, but more importantly, someone that may need urgent imaging. So someone that might have just been sent home with antibiotics at home now essentially can be sent for other imaging. So in this case, we got a CT KUB. It showed a mid-ureteric stone. And more importantly, what could have been just disposition home and return of worse is a urology and stent. And you may be thinking to yourself, well, yeah, I would just get CTs on those ones. But it's a very common symptom. And you really have to say to yourself, are you really going to CT every patient? Are you going to even get a diagnostic imaging on every patient that comes in with those symptoms? And if so, that's perfectly fine. But remember, these may be in environments where you don't have that urgent imaging. And it can be hard to prioritize this on the other demands of a department. So you've now used a point of care test where you've actually been able to triage that patient. Because if there's no obstruction, at least you can feel pretty confident about your original diagnosis. But more importantly, you've now changed the trajectory of the patient to something requiring a bit more of an urgent intervention. And again, they can tank pretty quickly. So even while you're waiting, you might want to get some interventions of fluid, urology, once again, transfer or referral a lot quicker. And just to kind of go through, like, what is the evidence of ultrasound and POCUS? This small journal called the New England Journal of Medicine did a really good comparison years ago, where it looked at the comparison of ultrasound versus CT for suspected nephrolithiasis, but included in there was POCUS as well. And it was not only was POCUS associated with a reduced cumulative radiation compared to CT, it was actually quite useful in the initial modality for ED assessment. So it actually helped kind of, again, triage who might need imaging and who doesn't. So it can be a really good frontline test for those. If we also switch to another really common upper abdominal imaging that we see, or sorry, abdominal symptom that we see, here someone comes in and they come in with right upper quadrant pain. And a very common one that we think about is it a gallbladder issue? Is it biliary colic? Is it cholelithiasis? And so what we have here is essentially the gallbladder. We can see the kidney in the far field. This is the liver up in here. And we're looking at the portal triad over here. And so when we look at that, not only can we make a diagnosis of, is there a giant stone, we can also see if there's something more going on again. So on the left, we have what is a gallbladder stone, a large impacted one here. We can even see it's like 3 centimeters in size. And so these patients have a high risk of going on to something more sinister like cholecystitis or an infection or just irretractable biliary colic. So once again, you can always bring them back there, but again, you at least have a better answer at that moment than your hand just jamming themselves in the right upper quadrant. Rather, you're taking a probe and kind of doing the same thing essentially, but you have a much better indication of when to get further imaging. And especially if you got something on the right side where you have the thick wall. So you got the pericholecystic fluid a little bit on the outside there. You got the gallbladder thickened wall. You've got just sludge within the inside here, and you have a bunch of shadowing right behind. You know much more that there's something more going on, even if their labs are negative, which is a very common thing that can occur. And so in this regard, this can be someone you may want to hold. This may be someone you just want to talk to your surgeon about, of saying, is this image good enough for them? And if not, you can still get diagnostic imaging. But once again, you're not just sending somebody home for imaging another day, for example. And the more important too is, where does this change the flow, right? So that's the other comprehensive thing is what else can this do to impact stuff? Sure, it helps with your own kind of cognitive ability to assess things, but it actually has a huge implication with regards to surgical referrals. So this one actually was a study that I did a couple of years ago, whereas at our center, we looked at the ability to say, well, let's say we used cholecystectomy as the gold standard. Taking the gallbladder out was the gold standard here of what actually was going on. And if we look back at the comparison of how accurate and how useful POCUS was, well, it actually found that the POCUS scan on a patient with a high suspicion of biliary pathology was super predictive that they would eventually need not only a surgical referral, but ultimately need their gallbladder out. So it kind of almost kind of put those people in a high DEFCON level or a high importance level of saying, these patients are going to need surgery one or another at some point. Let's sink a bit more resources into them and get them imaging. And so it can really help the flow of a department, the flow of a hospital, but also the bring back rate too. And if we kind of kick it up from there, when we look at imaging, we think about the heart too, a very common one, especially in the acute care environment. And so what we have in the top corner here is a subxiphoid view of the heart. And if we keep going around, we have a short axis view. Again, these are cardiac images. And then we have what is a long axis view of the heart, parasternal long axis. And then we also have another one down in the corner. And we have a compilation of all these acute scenarios. Large pericardial effusion. We already talked about this in the source of trauma, but imagine it was someone not in trauma and they came in hypotensive tachy. You're worried about things like pericardial tamponade. On the right side, if I was to say this is the left ventricle and this is the right ventricle, and it's this kind of large appearance, kind of pushing in a bit on the short version here, you basically got this enlarged RV kind of bullying the LV. So the RV is large in the right scenario, in the right patient, that can indicate a massive PE, for example. And the bottom left corner, we have like this heart that's barely beating. If you were to say that these were normal functions and this was a normal contractility, look at this. And it's just a very sad looking heart, essentially, not really contracting very much at all. And so, again, you can find out what is going on with that hypotensive unstable patient. But more importantly, someone who comes in with vital signs absent, cardiac arrest, you can basically see if there's complete standstill and make a decision for earlier termination. But what can sometimes happen is with POCUS too, you can use the cardiac exam for that. But if you start to actually find the average patient, the moments you seem to need it is when the images start to turn into stuff like this. A lot of air in the chest, gets all gassy, very challenging to get a good view and look around the heart. And so there's actually been an evolution with us too, where we've actually started to do transesophageal echo in the acute care environment, both ICU and emerge, and even anesthesia. Who use it for different indications, but it allows at least me as an emergency physician to have a higher standard to know what's going on. And so on the left here, we have what is called a TEE probe, and this is the TTE probe, transthoracic echo, or a phased array probe in this case. And so we've actually been able to adapt this cardiology-driven specific device to actually apply it and for a very different reason of why we need to use it. And so this is one of my fellows here, now staff, who's essentially with a patient who's intubated at the moment and being bagged, has essentially the TE probe trending down, and we actually put it down, and it goes in, back, and through the esophagus, looking at the heart from the posterior aspect here. And what that can be potentially helpful with is those cardiac resuscitation-driven patients. So in this case, we have this patient, a 64-year-old male, presents vital signs absent. He got epinephrine before he presented to the emerge. He's got a previous history of an MI and hypertension. And so if we look at his cardiac rhythm strip, it basically isn't doing a lot. And with no pulse and a strip like that, you obviously might decide to run things for a while, but the typical ACLS algorithm or in terms of cardiac care is to basically give epi and do compressions. There's not really much evidence for an asystolic shock. However, in this case, if we were to say, well, let's put the TEE probe down and take a look, what you're essentially left with here is if I was to say this is the left ventricle, right ventricle, right ventricle, left ventricle, it's the same heart essentially. And you're looking at the way it's moving, you can basically see very fine movement in here, despite the way that ECG looked. And so what it can actually help with is not only the guidance, but the resuscitation to say, hey, I might need to actually shock that. Maybe that rhythm strip or that cardiac strip isn't all that accurate. And so it can really be helpful to figure out, well, in that case, you may actually need to shock the patient. So in this case here, this is an active shock. So this patient is in vital signs absent. Again, left ventricle, left atrium, right ventricle, right atrium. And right here, you'll see the shock and then continued kind of cardiac motion. And so there's no interruption of during the cardiac care. You can actually shock with the TE probe in with these point of care imaging modalities. So it can be very helpful in those cases. And so this is a study basically that is a feasible, useful, clinically influential tool for us in a POCUS program, is that this technology that was never thought to be even remotely on our radar of utility basically can be brought down to the emerge and utilized in that acute care environment. And so the study basically examined that saying, yeah, this is definitely something we can do. If we kind of extrapolate that a bit more, this is a 17-year-old male that presented who was completely hypothermic with a GCS of 3. So basically, he was completely no vitals, not doing anything, but profoundly, profoundly cold. And he was found in a snowbank. Obviously, snows here in Canada. And depending on where you are, you may or may not experience something like this. But typically speaking, uh, we rewarm these patients, and this is a TEE that was inserted. And it actually has a bit of a temperature probe. It's a little bit down the line of when the original temperature was, but you can see here there's not much happening in terms of the cardiac care. And so as we rewarm the patient, it's actually quite eye-opening to be able to have basically a complete visualization into the heart. So if this should start here. There we go. And so this is the same patient over a number of hours being rewarmed, being given IV fluids, bear huggers, and just it's incredible to see how much the heart kind of rebounds. But you're not just going off blood pressure. You're not just going off a manual pulse trying to feel it. You actually have a complete window in there, and you can leave it in the whole time. So it's just another visual display of how the heart's functioning and how impactful this can be for us. And this is another one that we commonly occur, the shortness of breath. So this is obviously a chest X-ray, and this patient's coming in, and it's always sometimes hard to say like, okay, well they're short of breath. There's something going on that left side, and but at the end of the day, it can be very hard to know, is that complete consolidation? Is that a whole bunch of pleural effusion? And so again, where POCUS can really be helpful is trying to zero in on that a little bit, essentially looking at that side. And so what we have here essentially is that here is a large pleural effusion that essentially with a collapsed lung right here, or is it a complete consolidation or hepatization of the lung? So on the right side, these are two very plausible scenarios to look at to see what's going on when you're looking at this chest X-ray to say, is there something else happening? And here you basically have a complete whiteout of the lung in the sense that this is consolidation. It's probably full of pus. It's probably more pneumonic versus, hey, I should probably stick a needle in there or drain it or get a tap. You can also use it to do the anterior parts of the chest. So what we have here essentially is the is a chest ultrasound in terms of looking at the lungs and saying this is lung sliding. This is something called an A line. And basically looking at the wall, say, is there a lot of what's called B lines or signs of fluid overload for the rest of the chest? And in comparison, this is what it would look like if there was. So these are B lines here. You can see the white shimmering coming down from the pleural line on both sides. And essentially, it really shows you that there's a lot of signs of, potential inflammation. It could be fluid overload. It could be an ARDS. It could be really severe bilateral pneumonia. So it's really important to take that into context of the rest of the stuff when it comes to the patient. You can also use it in terms of the accuracy. So these are some studies looking at basically pleural effusions in terms of the accuracy pleural puncture sites. In this one, this actually compared the prospective analysis of people doing clinical exam with ultrasound and determining, well, if I took respirologists and residents and trained staff and said, hey, tap, kind of percuss around the lung there and use your physical exam and say, would you tap it? And where would you tap it? And it was actually quite impressive to say how many times using the POCUS afterwards and looking at the lungs, it either changed their decision of where they would puncture or even if they would do it for better or for worse. So sometimes they thought they would do it and then they looked and like, oh, there's not much there. So they decided not to. And that was obviously based off their clinical exam. On the flip side, sometimes they felt like, I don't think I will. And then they took a look and it can be very humbling how eye-opening it can be. And so when you kind of bridge that with the concern of why don't we just tap lungs? Well, it's because there's a chance of injury. And pneumothorax rates obviously are very something that we really care about, especially in the hospital environment. And that ultrasound guidance reduces that risk, essentially. The idea that you don't need to always just blindly tap, but rather it can give you a prediction to say, well, should I or shouldn't I? And more importantly, it reduces the complication rate with it. We also have this other one as a bit of a pivot from the heart and lung. We have the sudden visual loss, and it can be really helpful in determining what's going on with that eye that suddenly someone says they can't see with. And so, if we were to say that this is the eyeball, so a big circular structure here, you can obviously see this probably is not normal. And that can be very impactful, especially when someone says, doc, I couldn't see anything, or I could see before, and then suddenly it's all blurry, and more importantly, it kind of looks like a black curtain. And we think about things like retinal detachments. But again, other than visual acuity and checking confrontational fields, there's not really many other tests other than a discussion with an ophthalmologist doing a direct visual of the fundi. POCUS can be helpful in giving you a better idea of what's going on in there. And so here are just two comparisons on both sides in terms of how bad it can be. Not only seeing the complete detachment of the retina, but also how much like a hemorrhage can be on the inside as well. And so when we actually pivot from diagnostic parts, and I'm going to give you a bit of a context of something that happens here in London where we have hip fractures. And so we have someone that basically comes in with left hip pain, post-fall, can't weight bear. They have quite a few other comorbidities such as COPD, the cognitive decline like dementia, chronic kidney disease, and heart disease. And so POCUS, just to be clear, is not making the diagnosis of a hip fracture. We still use X-rays for that. And so we know there's a broken hip there, but we think to ourselves, well, what else can we do for it? And so there's always a risk, especially when you give someone unneeded sedation. More importantly, just giving IV pain meds and narcotics can worsen some of those states as well. You want to control their pain, but it may not always be the best thing for the patient in terms of all their other risks that come with it, because they can worsen things like delirium, for example. And so, what this actually can help with, and where POCUS comes into play here, is the procedural aspect. So, there's a lot of background about the benefits of actually doing regional nerve blocks for hip fractures and helping reduce the pain. And so it itself is not a revolutionary concept. That's been done by anesthesia for years. But again, that's through a specific training program. And more importantly, people don't feel comfortable. Acute care providers and emerge docs have to know a lot about a lot, to be very honest. And it can be really hard to keep those skills up and be fluent at everything all the time. And same thing as the expectations rise in the healthcare centers around the world, it's important that we think of novel ways to apply this. And so how can you actually make people a bit more comfortable doing things like regional nerve blocks? And that's not specific to this nerve itself, but it could be for anything specifically. But here we're talking about femoral nerve blocks. And so what the ultrasound's really good at is giving a better idea of what's going on. So if I was to tell you that this is the vein, this is the artery, and the nerve lies over here, what the ultrasound does is it gives you basically a visual display of what's happening. And this is the fascia lata and the fascia iliaca. What we essentially can use the ultrasound to do is actually visualize the needle go right in the spot. So what the ultrasound's actually doing here is acting as a bit of a conduit and more importantly, a procedural guidance for maybe something that someone wouldn't feel comfortable doing before, making it more successful and making them a bit more confident in providing care. And in that same vein, let's pivot to something like fracture management, which combines a bit of two different areas together. So we have this happen all the time, the old fall and break the wrist. And it can be a bit of a showstopper sometimes in the emerge. At least here, for example, this patient may present with this wrist, and what we'll do is we'll sedate them, or do a block around in there in terms of a local anesthetic. But even if we sedate them, we'll reef on it, we'll pull it, maybe have orthopedics involved, and we'll do all this stuff. We throw this plaster cast on, and then it comes back looking like this. And your heart just sinks because you go, oh my God, I gotta like find the cast saw. I gotta explain to the patient, we gotta redo this again. We have this mushy plaster cast, if that's what you've used, or even a splint, and we have to remove the whole thing and start all over. And that can be very impactful in an environment where you are now off to the next patient. If you're seeing hundreds of patients a day and the acuity is really high, you may not have time to go back, or I mean, you're going to have to, but it just sucks that happened. And so the question of, do we sedate again? Do we repeat the block? And it makes you feel like you just want to do this to yourself. So there has to be a better way to do it. So that's actually where POCUS kind of puts a bit of diagnostics, but also procedural elements into play. So let's use if we use the same POCUS machine, we use a linear probe this time. This is a distal radius, and this is a normal one here. And what you're basically looking at is a bright echogenic line. Should play here. No, can't play. What you're looking at is a bright echogenic line right along here that essentially is going to show bone. And what you then eventually do is, if you have a broken one like this, you're going to use the probe, and you're gonna scan all the way down, and it's going to show a delineation between two broken segments there. You're going to scan all the way down. Oh, and the clip didn't play, but usually there's a discrepancy in the bone. And then what can happen is, after the reduction itself, you'll be able to look at those two fragments and see them align a lot better. And so there, it actually helps you with the reduction piece of making sure two bones align. So again, not going back and forth to radiology imaging. But it can do a lot more too. So we actually do hematoma blocks quite often. Sometimes we don't actually want to do a full sedation. And so we actually want to stick a needle right into those bone fragments and inject some lidocaine to actually give it some numbness. It can be especially helpful when you have an arm like this, for example, that might be very challenging to do a full sedation for. And so if we give the example that we just did before, again, broken bone, and we want to do a bit of a hematoma block right in here, just to give a bit some more relief. Here, we're looking at the bone itself. We're looking at the fragment right up in here, and you're actually looking at this kind of small discrepancy in there, and you can actually target the needle so it goes right into play. And so this is an example here of the ultrasound needle, as you can see to the side, and you can basically laser it in right into that small space and inject, making it basically a very successful procedural injection, and making your confidence a bit higher to make sure, did I just jam it into a big swollen area with a big hematoma, or did it actually get into the bone space? And so at the end of the day, you have a patient like this that you may actually have done a block on, and you can use the POCUS both for procedural and that reduction element as well. And these are the pre and post films. So where it comes down to, and where I was just, it's kind of hard and impossible to give you a complete perspective of everything POCUS related, but it's more important to kind of recognize everything here. You have cardiac, you have LV function, pericardial effusion. We just talked about TE rest. We talked about stones and cholecystitis, but there's a lot more to biliary with that too. We talked about OB, vascular, DVTs, and it was just, and there's more to that too. But DVTs are a big one that we didn't talk about here today, but there's a huge use. And when it comes to respirology, we got interstitial syndromes, consolidation, effusions, GU. We can talk about bladders. We talked about hydro, but bladders are huge too. Figuring out why is that fully not working? Why is someone bleeding? We talked about abdomen a little bit, but more importantly, you can use it for things like small bowel obstruction, for example, too. Looking at for dilated loops, which can be very challenging if you don't have a CT to figure out what's going on, given that X-rays really aren't always the best thing for it. Ocular is really helpful. We talked about that. And you can actually use it for airway too. So the idea of being able to intubate and use it not only to confirm if the tube's in place, you can use it dynamically and put it here, but you can also use it for cric landmarking. And then it can even pivot into things like soft tissue, things like cellulitis, abscesses, foreign bodies, and then all kinds of procedural elements as well. And so where it comes down to is that POCUS is used by a lot of services. I'm an emerge doc, but certainly in critical care environments and ICUs across the globe, it's used a lot. And it may be for different purposes. Not everybody has to be proficient at every scan. And that's, I think, a key element is what's specific to your discipline is what you take back from POCUS. POCUS itself is a modality, but all the different indications really stem from radiology indications and now applying it to your own environment. So in critical care, they'll be doing some much more advanced cardiac stuff that really I don't care as an emerge doc. It's not important for me that day, but it could be important for them dynamically, whether it's for pressors or fluid management. And the same thing goes with internal medicine, a bit of a different breadth because they're maybe visualizing patients day to day and they see different indications. Anesthesia obviously wants to use it both for procedural and even intraoperative guidance. Surgery, it might be there for certain procedures, things like chest tubes, post-op care. Cardiology, we talked about them, and obviously echoes is like they are the experts. But After that, things like lungs are very important because it's the other tank of the body. If we think of the heart as the pump, the veins as the pipes, and the lungs as the tank, they don't know as much about that sometimes. And so it's important that they be able to apply POCUS to look at lungs, looking for all those pleural effusions and B lines and everything that we talked about. Nephrology can be very helpful for dialysis pre and post, but also procedure for their lines. And pediatrics, I mean, you got kids where you don't always want to expose them to a lot of radiation, and it can be really helpful when you got these like black boxes of individuals who can't always verbalize stuff to you, but you can get a much better idea of what's going on in their lungs, for example, their belly, and also their hemodynamics. And even beyond the hospital, POCUS is pretty helpful. And this is where kind of the evolution keeps happening is that things like palliative care. And so there's a lot of use sometimes in community services where they might actually bring the machine to someone in a hospice or even at home who might be at end stage who don't want to go to the hospital for certain procedures. Being able to do things like pairs and thoras or even diagnostic kind of tests at the bedside is huge. And that can be very helpful, not only just from an economic point of view, but patients love it. And so feasibility of that when it comes to things like EMS as well, so emergency medical services, they can use it in those kind of deployed environments to maybe triage patients and give better ideas of what's happening. So there's a lot of evolution beyond that. And so when we think about POCUS in medicine, it's kind of a good way to look at it from five different points of view. Resuscitative, those hemodynamics. Symptom-based, chest pain, shortness of breath. I'm going to do it for a reason that you presented with or you're complaining about right now. Diagnostic, I have a better idea of what's happening, but I need more of a firm diagnosis. Procedural, the guidance and stuff we talked about. But the other element's the therapeutic value. The idea that patients feel much more satisfied when they come in and they feel that they're actually looked at. And it sounds weird, but a patient that you hear a whole story for and maybe don't lay hands on, maybe doesn't feel like they got the time of day, even though maybe in your heart of hearts you knew that they never needed it. But things like stethoscopes, I think, are still important, but sometimes I do it because it's part of my routine, but patients feel a bit better about it. And to build on that, bedside ultrasound actually maximizes patient satisfaction. You bring this cool device where you can show them pictures at the bedside. Patients love it. And at the end of the day, it's you also want to make sure patients feel like they were heard and that they got proper care. And so it maybe they didn't 100% need it, but it's also a bedside test that's no different than you pressing on their belly. You feel a bit more reassured, but the patient feels a bit more reassured too. And that there's something to be really said about that. And so we go back to kind of the disruption that POCUS had. And at least here, when we talk about the acute care environment, it helps rapidly rule in and rule out unstable patient. It's really good for diagnostic accuracy and time to diagnosis. It's really good for procedural safety and accuracy. It's repeatable. And again, I want to reemphasize, you can just keep doing it. You can look at the heart 5 times. You can look at the heart after you give pressors. You can look at the belly after the blood pressure tanks. And more importantly, it improves things like length of stay and return visits. People don't wait as long for diagnosis tests. Maybe they don't need because you feel pretty confident in your skills. And like anything, though, there's always a light side and dark side to everything that we do here in medicine, and POCUS is no different. And that the way to look at this is that it's a data point. It's one of many things happening, and you should never rely just on a POCUS. If you show me a bunch of images, I can give you an interpretation. But you should also compare it to all the other things going on with patients. Who are they? What are their vitals? What are their complaints? And then you put that in context. And so if I was going to take a patient, it's very rare that I would just look at no images, or sorry, no vitals, and just look at the images themselves. Rather, we would look at the IVC, we look at the heart as well, and the way it's contracting, and we look at the lungs. And we can take a patient with all those things. We talked about pipes, pump, and tank, and we put it in context of the patient themselves, vitals, heart rate, oxygen. And it's another data point that can help get you further to what it is you may need to do. And so as we kind of near the end of the talk here, we start to talk about what are the perceptions? Like, what do people think of this? Because again, when you disrupt a current paradigm, uh, people don't always take too kindly or they may not really respect it. And so this was one that basically was the perceptions of POCUS performed by emerged physicians. Essentially, the surveys were sent out to internal medicine, general surgery, OB, saying, what are your thoughts? What are your thoughts of all these acute care providers doing it? And IM actually were, significantly internal medicine, were pretty significantly much more likely to actually trust it. But again, they're kind of part of that same cohort of, well, we're also using it. So I kind of get it. And we're talking the same talk about this new disruption. But more importantly, things like OB were less likely. Remember, in a lot of centers, they may be the ones doing a lot of their the OB ultrasounds after all, right? And so to them, they don't really trust it as much because they don't feel like the same amount of time to learn the skills has been heard, and the confidence was much less. And in fact, we did a study here looking at surgeon perceptions. What is a surgeon's perception of POCUS? Like, which is kind of curious. Like you can do all this stuff what's best interest of the patient. But if no one cares, it actually kind of diminishes your desire to do it. And so this one was basically a cross section of all these surgeons across different environments in Canada. And essentially 88%, so a good chunk, oh, they knew emergency department biliary point of care existed. But almost 60% had a total, and I want to emphasize total lack of confidence in biliary POCUS, with a quarter being slightly more confident. So essentially, everybody who was aware basically weren't ever that confident, right? And so it really kind of highlighted the importance of saying, well, geez, like, what are the factors behind this? And when we look at it, there's, what are the factors causing that reservation? And, it's things like the lack of certain details, the lack of documentation and report, and actual ownage of like writing things down, or having imaging into a like a standard PACS machine or system, for example. Being able to actually know who it is doing the studies. And those are, I think, probably some of the most important things that you don't sometimes know who it is on the other end. So because it's a new technology in the last 20 years, and more importantly, still trying to evolve itself in our current medicine timeframe, it's hard to know. Like I know you know how to listen to a lung because that's so core and fundamental to medical students and medicine. But I don't know if you actually know what you're doing with POCUS. And even if that's the case, you didn't save any clips. I can't look at the pictures. And you're deciding not to write it down. And so those are a lot of factors to say, well, why would I trust you to do it? And although interestingly enough, like any surgeon, if they could do it, they would have confidence. So it's not that it's the modality itself. It's not that biliary POCUS can't be done. It's that there's kind of that lack of bridge of trust. And that like if someone is doing it themselves, they get the pictures, they get the patient, therefore they're going to trust it a lot more. And so it's kind of one of those classic scenarios of like there's no more gift precious than trust. So especially in medicine, if you don't trust the other individuals, what's the point of doing all these tests sometimes? And so this is just an example of one of the different kind of workspaces that you can do to save. And so this is a one from what's called QPath, and there are new versions of it and different programs that exist out there. But it's the idea of actually being able to record and more importantly, have a record of your of imaging findings and saving them in some sort of workspace environment. And that can be done on a PACS machine or something like that. But it's again, just saving images, having a way to look at it, and then more importantly, recording it. And we here at our organization we use Oracle Cerner, one of the EMRs utilized globally. But we've actually started looking at actually putting a subsection on there of being able to actually have a spot where the point of care imaging is part of this, and more importantly, having an actual record of it as well, making sure that there's an actual log of it and that it shows up on the record system, and people can actually see what someone may interpret it as. And once again, just an example here of, how it can pump out too. So this is a comprehensive cardiac one, for example. And so, at the end of the day, it picks or it didn't happen. And I mean, this can be applied to a bunch of things in life, but definitely in an environment where we're imaging modality, not maybe knowing always the other person, we want to be able to save images. And if you can't save images, I mean, that is, I don't want to say a different problem. There are solvable ways to do it. But you really want to, if you want someone to act on your images, you have to have some sort of record or even show them or something. There's got to be some bridge there. In a perfect environment, everybody would be fluent and trustworthy, and you'd all get on board. But that's not always the case. And so I kind of always like this one here. I hear it quite often like, well, point of care imaging, I don't have time. I can't learn this. It's a new technology. Well, this one looked at if an eighth grade student can learn it. And the answer is yes. So anybody can learn it with enough training. And training is probably the most important thing and sometimes the hardest thing to achieve, depending where you are. And so, where does that kind of lie in terms of, where things are going with POCUS? And we start to see this like evolution. We start to see this evolution as we go down. We have all these tools, and we've gone basically from this now stethoscope. And you know, you hear the term POCUS is a new stethoscope, and I don't know if it's the new stethoscope. It's definitely a new tool. It's definitely replaced a lot of things I use the stethoscope for. But stethoscope's pretty easy, and I call it a wheezoscope. You can't hear wheezes with POCUS, but I certainly can still listen to a chest with it. But what the ultrasound does is kind of unpack those sounds, or more importantly, it kind of unpacks that black box of an individual. Instead of putting the stethoscope on, I might listen for that, but more importantly, I'll put the ultrasound on, and it's giving me much more useful information. And so it's like any other tool that kind of comes into it. You know, a new tool, maybe someday we'll get here too. But I just want to finish with, you know, a lot of work at our institution of, you know, you've heard all this talk here today. You know, here in London, it has taken a long time. And I would say we're in that kind of junior stage of where POCUS evolution is. We've run courses, we've done interdisciplinary rounds, we've worked with providers. These are all different consultants and me too. And when I guess I had wasn't as stressed, and more importantly, just being able to show people what it is and teach them and kind of have this more collegial relationship when it comes to ultrasound. So training is important, but working with other providers and those even current sustainable environment like radiology and cardiology, the people who use the current technology, it can be a real good bridge to know where the gaps lie, more the education, but also show to individuals that like it is here, but we're not trying to replace jobs. We're just using it for different reasons. So at the end of the day, I always like to fit, you know, POCUS is still awesome. I love it. But I hope this gives you a bit of perspective of where it's kind of evolved in our clinical care and how it's taken a current technology piece and adapted it to a point of care environment. And I'm happy to take any questions now. And I apologize. I saw the chat kind of blow up, but I didn't know how to open it while I was presenting here. So happy to take anything now.
Thank you very much. Thank you for the awesome lecture. Quite relatable and amazing. And for the participants, please, do we have questions or comments? Can we drop them in the chat box? Somebody is asking, how can one become a trained POCUS expert in Canada in terms of qualifications?
Yeah, it's a good question. The qualification for POCUS is will always be a hot topic, and there are different certifications one can achieve. But I do want to caveat with this that wherever you work, POCUS, in my opinion, should be a democratized technology, in that you should not use anything you don't feel confident with. That's for sure. So on the flip side, we do things like you know, no one gets an airway certification. They do residency training, and so they feel much more certified in the way that they've gone through this training process. And I think as residency programs across the globe and medical schools start to integrate POCUS a bit more in their curriculums, it'll be less and less a topic of conversation. But as it currently stands, if you're someone in Canada or you want to get training in Canada, there are ways to kind of demonstrate and get certificates, whether that's going through different organizations. There's one called CPOCUS that exists across here, cpocus.ca, and they provide different examinships and certifications. But again, a certification can be helpful to demonstrate to your environment that you've done extra training. At the end of the day, if there's no absolute requirement to need a certification, but rather it can be a helpful kind of, I don't want to use the term merit badge, but it can be a very helpful way to demonstrate expertise. And that's how I would use certification a bit more.
Oh, actually, Frank, I'm glad you answered that question in a more general term, as opposed to expertise in Canada, because this seminar is more so for doctors that are working in and practicing in Africa. And the aim is to actually improve their qualification, not qualification, but the experience and their work
Sure.
environment in Africa. So the aim is in Africa, not in Canada. But I'm
Yeah.
glad you gave that, yeah, give that generic
Yeah.
answer.
It was
We're not
termed.
training doctors to work in Canada. We're training doctors to
Oh
work.
yeah, yeah, yeah.
Yeah, yeah,
Well, I just said it said in Canada
yeah,
specifically, but
yeah. I
but
know, I know,
I
I
and I
know. Yeah.
but I want anybody to take that back to their locations, and again, I'm not going to pretend I know the environment in Africa in terms of all this certification and what's needed. Sometimes, for example, a comparison in Canada is, you know, sometimes to even do small things in nursing, you need all these little qualifications and certifications. I would look at it as what's in the best interest of a patient. You don't need a certification to read a point of care ECG for those, STEMIs or heart attacks. You don't need it to just be able to look at an X-ray in the acute care environment. You do if you're a radiologist for sure, and that comes with like residency training. But where I think qualifications can be helpful is if you're in a location that has never used this and you're trying to be the leader, it's really nice to say, I went to this outside place and I got some recognition. That means and that may not mean anything to your institution or even your country, but it shows your chair, your chief, your department head, your CEO that you basically have like, I am an expert. I went and did this thing and jumped through the hoops that has been utilized in this other country. Therefore, maybe that can be helpful to demonstrate competence, but it should never be a barrier. If you get the expertise and you're self-taught and you feel confident, I would just say work with your individual institution. If you have radiologists, cardiologists, if you have access to other experts, even within this kind of organization and this connection, I think that is enough of itself to start to demonstrate, because you can't develop confidence or competence until you utilize it in your clinical environment. And so I would encourage you to, like, however you practice now, keep practicing it. Just also maybe use the ultrasound probe, but then get your other imaging as you would have before, and you'll start to kind of learn how right and wrong you are. But I will always say a probe in a patient that has no access to imaging is always better than dealing with that unknown quantity. So definitely take that back, but you don't go rogue. Don't use this lecture as oh, I was certified online because he told me I didn't need it. Maybe do a little digging before you start to apply it in your environment.
Yeah, thank you. Thank you very much. Thank you very much. In Nigeria, particularly, we'll recommend that as radiologists because you should have gone through the training before you even begin to handle the probe in emergency situations. So thank you very much. I want to ask, so the probes, is there a particular one that has different frequencies for the abdomen and superficial scans and deep scans? Is there one probe that could give the different adjustments for the frequencies, or you have to remove and fix? Or
Yeah, it's a good question. So the typical three main probes, and obviously there's a lot of, gray areas in between there, are the linear probe, the phased array, or sometimes called the cardiac probe, that little square one, and then the curved linear probe that looks like this. There's obviously smaller indications for ones like pediatrics, and there's the transvaginal probe or endocavitary probe for like uterine scanning. So there's variations, but the there I would say some of those probes I showed earlier in a way back earlier slide, some of them actually are pretty good at like doing multiple things. I will say it's kind of like trying to do carpentry or building. Like you can hit a nail in with a drill by hitting it like this. It may not be very good, but it still gets the job done. And so I would say, depending on what it is, if you're doing things like procedural and superficial, you want the linear probe. And most of the time, the linear probe, you can very easily tell on there. The phased array and the curved linear start to overlap quite a bit, in that the phased array probably is your jack of all trades, if you will, but it's not perfect for everything, and more importantly, it's not really good for like certain procedural stuff. So there's ones that I'm not going to endorse any specific company or anything here, but there are certain probes of the portability, the portable ones you can plug in, that actually can be flipped between different versions and the frequency can be changed. But recognize that that's at the cost of being really good at one thing and might just be mediocre at a few things. And so if you look at a cart-based probe, they probably have all three of those common ones that you see there, and you can just usually flip between them by pressing a button on the machine.
all right, thank you. Thank you very much. Any more questions? Does anybody have a question? Okay.
Actually, I have one. I have a quick one. Frank, these probes, I mean, like, coming from a sustainability maintenance aspect of it, they're obviously a bit more cheaper, a bit more portable.
Mhm.
Which means that I don't know how long the lifetime typically is. Even though they're on the cheaper end, they're still quite expensive for this setting. And so the question is, if an institution was to invest in maybe a couple of those probes for the ER, what's the typical lifespan for them, and how long do they think they could get good uses out of it before it goes to the graveyard?
Yeah, great question. So the cart-based ones I showed you, it's kind of the cart-based ones usually have a pretty good lifespan. We still have some here in London that we bought 13 years ago that are still kicking. So like now, granted, I'm not going to say it feels like it just came fresh out of the box, that there's like, some little errors here and there, but they actually last quite a bit. I would say the average cart-based lifespan for a place that uses it very often, like all the time, high frequency, probably somewhere between, like 8 to 10 years, right? But again, that's a very just broad stroke paintbrush. But if you're somewhere that maybe uses it once in a while, it probably will last a lot longer. The handheld probes is a bit of a harder one because they're relatively new in the grand scheme of the last decade. So I can't give you firm numbers on that one, but they seem to last pretty well. Where the parts that they don't last as well for are things like where the cords attach, which is I think just from wear and tear of things with time. But for the most part, I've not heard a lot of the new handheld probes breaking very often. And when we talk about things like cost point, for example, some of those probes I showed you, you can buy some of these probes, like the handheld ones that like wirelessly go to your phone, for like probably like 2 to 3,000 US at sometimes, right? So there is price points that are achievable depending on what your hospital system is. Granted, those aren't always the best ones, but I would say in this day and age, it's like most probes can answer the questions that you need at the point of care. So I think it's a good like soft launch into those realms if it helps. If you have nothing, it's a great way to start down that pathway. And then if you show and demonstrate utility, you can advocate for more funding or more kind of sourcing to be able to get the, I don't want to say bigger and better machines, but the more kind of robust ones would be a good way to describe them.
All right.
Uh,
Thank you. There is
no
one more
worries.
question.
Yeah,
Said,
the ocular scan images you show, what's the definitive management for such a patient? Referral to ophthalmology. That for in those cases when you have things like that where it's so in your face, I assumption would be that they have some sort of visual impairment or visual concern. Not much I can do for them, or at least as an emerge doc. It would be referral to an eye specialist or an ophthalmologist or a specialist who ultimately can glean in there. And I'm not going to pretend I know all the different treatments for a retinal detachment, but that would be the next referral pattern for him or her.
thank you. Thank you very much. Dr. Frank, we want to appreciate you for your time this evening. We do not take it for granted. Um, I do not know if there are any further comments. Dr. Duna, any further comments before we wrap up?
Yeah, no, Frank, this is fantastic. Thank you so much. Like it's like Dr. Des said, a lot of the points you've made and even given the examples, it was very conceptual to pick up. And it's always good to learn from somebody that is really doing the work and seeing all of the different cases and looking at it from all of the different angles. So this is great. I will reach out to you later on, like I said, to figure out how we can do this again, but maybe with some live demos, not in emergency setting, but maybe with some students, medical students, or demos or something, dummies or something like that, because that would be very, very useful for them to also see that in practice. So I'll reach out to you, figure out how we can do that next year. But again, like Dr. Des said, we thank you so much for your time. We know you're super busy. Some of the fellowship programs we develop in the West at Western would be nice to see how we can adapt that and develop that here as well. So I'll reach out to you for that. Eva, is there anything you'd like to say before we wrap up?
No, that's it. I also just want to say thank you. I think this was very clear. I'm mostly using MRI, so for me that is really a very new topic and I learned a lot. Thank you.
Oh, thanks for having me. And I'm not going to pretend I know much about MRIs, but a lot of the common, if MRIs became so portable, you could just like, like literally do the same thing. I
Yes.
literally all the same problems are going to be something you eventually encounter. So it's all about that paradigm of like a new imaging and democratizing it for all to use.
Yes,
That's the
definitely. That
best
would be
way to
great.
end that. Yeah, democratizing it. And Marina, for example, she's developing portable MRIs for wrist imaging. So that's going to be coming to to an emergency room very soon. And Frank, a lot of the stuff you mentioned today, like you said, we can port that over to MRI. So thank you so much, Frank. And we're gonna call it a night here. And for everybody else, a seminar will be back next month. And we have a new speaker. Eva, do you know who's speaking next week? Oh, next month, sorry.
Oh, sorry, I would have to pull up the list. Just 1 second. I can get it up so that we know.
Yeah.
So just 1 second. So next time it's Daniel Sodikson on, I think, low field MRI. Yeah, but I think it's still open. The title is still open.
Yeah, so that's a good follow-up from you, Frank, because that's what I thought. That would be speaking about low field MRI, which has the potential for portability. So it's really got a great segue from your talk. All right, everyone, thank you so much. Have a great evening for those of us in Africa, and
Thank you.
have a great afternoon. Thank you.
Thank you very much.
Thank you. Bye.